The following podcast is part of a certified educational activity titled Optimizing Obesity Management Before and After Bariatric Surgery. The role of anti-obesity pharmacotherapy to reduce weight and obesity-related comorbidities. Access the entire activity and complete the post-test at peerview.com/RDF860. Downloadable slides and practice aids are also available.
Hey, wasn't that band something? Thank you. You're a fantastic audience. Welcome to this candid conversation on optimizing obesity management before and after bariatric surgery. I'm your host, Dr. Christopher Still from Geisinger Clinic in Danville, Pennsylvania, and I'm joined by two distinguished guests and friends, Dr. Donna Ryan from Pennington Biomedical Research Center in Baton Rouge, Louisiana, and Dr. Alan Whitgrove from sunny Del Mar, California. We're delighted that you've joined us for this dynamic and wide-ranging dialogue as we attempt to answer how do anti-obesity medications fit into the surgical practice. Okay, let's get started and talk why weight regain is not uncommon and ways to mitigate it after bariatric surgery. So this is a slide from labs that I think is very important. If you look, there's the honeymoon phase, really, of the first 6 months, where everybody really loses an appreciable amount of weight, about 25%. And then, like any other treatment modality, there's different differentiations of some people lose weight and some people don't. Just like blood pressure medications, some blood pressure medications work, some blood pressure medications don't. So same thing with regards to the trajectories after bariatric surgery. So really after 6 months is the crucial point where you really want to follow your patient to see which trajectory that patient goes. Is it gaining weight, losing weight, or staying right on track? So weight regain following surgery, as I said, is not uncommon. And really, after about 6 months, there's a normal weight gain of about 10 to 15%. It usually occurs about 9 to 12 months after surgery, and we really want to consider anti-obesity medication early on because we don't want the patients to gain weight because then we're back at that weight loss phase. We want to intervene early and try to stop the weight regain after inadequate weight loss or when they start to gain weight. And to help that, continued accountability and follow-up provides the best chance for early intervention. And at Geisinger, we developed this free app. It's called Get to Goal, and it's in the Android or Apple store. And all it does is really it tells patients where they are at the time of surgery, and it gives them the quartiles of weight loss that they can expect after surgery. And actually, you can put your weight in before surgery, and it'll give you your expected weight loss for realistic expectations after surgery. But more importantly, once they have surgery, they should get weighed on a weekly basis, and it'll really document where they are on their weight loss journey. And when they stop losing or start to gain initially, that's when we want to intervene. And so when we have someone, here's a suggested workup that I like to do. Number one is define the anatomy. All patients come in and say the surgery doesn't work. I can eat more. And it's important to say, well, let's look at it because the patient will say, I need to go back to the surgeon and I need a redo. And oftentimes that's not the case. But initially, we want to do an upper GI or a CAT scan or endoscopy to define the anatomy to make sure there's not, number one, a GG fistula, or number two, the anastomosis is not enlarged. And if you see a GG fistula, that's something that can be corrected surgically. But most time, the anatomy is just fine. But as I said, I think it's important to do this because in the patient's mind, they think that something is wrong with the surgery and need a redo. At Geisinger, we send them back to the surgeon because it's important, I think, that the surgeon say everything is okay. Then they send them back to us to work on their postoperative weight gain or inadequate weight loss. The second thing is dietary intake. We know the further along you are out after surgery, our dietary patterns change in what I call dietary indiscretion. So it usually occurs, as I said, about 12 to 16 months after surgery. It changes from protein and very little carbohydrates to more carbohydrates, complex carbohydrates, and they go from this strict 2 to 3 meals a day to more of this grazing type of mode. And the macronutrient composition also changes from predominantly protein to more complex carbohydrates. And the complex carbohydrates increase appetite, and it also has that soft calorie syndrome where it goes down quickly, they get hungry, and they go into this grazing type of mode. The other thing that happens with increase in carbohydrates is the small bowel adapts. So initially, when patients, at least for the gastric bypass, when patients eat simple sugars or sweets, they get dumping syndrome, they get nauseous, and they avoid it. Over time, when you tax that and continue to eat carbohydrates, your small bowel adapts and you can eat carbohydrates all day long. So dietary indiscretion, I think, is one of the things we really need to look at. And if possible, we need to send our patients to a dietitian where they can really take a good dietary recall and see what their macronutrient makeup is. The other thing is we know is as we lose weight, we lose significant lean body mass. And when we decrease lean body mass, it decreases our resting energy expenditure. So the only safe way we can maintain our lean body mass is by exercise. Again, in the first 6 to 12 months, everybody's very diligent in exercising and weight-bearing exercises, but over time, that kind of diminishes. So exercise is key, not so much to lose weight, but to maintain what weight we've lost. So physical activity and weight-bearing exercises, very important. The next thing I like to look at is depression. We know that depression is much more common in patients with overweight and obesity than the normal weight individual. And after surgery, the honeymoon phase, everything is great. Oftentimes, patients that have depression go off their depression medication. But we know patients often self-medicate with food, specifically complex carbohydrate. Those increase serotonin, give us that calm and content feeling, and over time, we go in that grazing type of mode. So even though patients are on medications for their depression, we want to make sure that it's really being treated. So we do Beck depression scores, or there's a whole host of depression inventories you can do. But you want to make sure, number one, the patients aren't depressed and their depression medications are working if they are on medications at that time. We want to avoid weight-stimulating depression medications. Most of the SSRIs are weight neutral. Paroxetine, which is a great medication, can cause weight gain in about 22 to 25% of individuals. The other thing is we want to encourage these patients to get back into group support groups. Now, oftentimes they don't want to go back to the larger support groups because they're gaining weight and they're mortified. So we have back on track smaller support groups for these individuals. And oftentimes we try to break that grazing with carbohydrate with short-term liquid diet. And that sometimes helps very well in patients that have this grazing type of dietary intake after bariatric surgery. The next thing, as I alluded to, is medications. Prescription medications that can promote weight gain or retard weight loss. And it's estimated that 10% of the obesity epidemic is iatrogenic, meaning what we prescribe as prescribers that can promote weight gain or retard weight loss. So here's just a list of some classes. You know, the anti-diabetic medications. We've come a long way. Insulin causes weight gain or retards weight loss. The sulfonylureas, the thioglutamines, all great medications, but they can and do cause a significant amount of weight gain. Antipsychotic medications are lifesavers, but they do cause weight gain, even whether you've had surgery or not. I talked about the antidepressant medications, the antiepileptic steroids, and antihistamine. So the bottom line is I think it would behoove your patients is just to take a good medication reconciliation to make sure they're not on medications or we're not prescribing medications that can cause weight gain or retard weight loss. And then finally, whether we've had surgery or not, the physiology of obesity and weight regain is continuing even in the bariatric surgery patients. So after a significant amount of weight loss, our body adapts both hormonally and metabolically. From a hormonal standpoint, the hormones that occur without surgery also occur after bariatric surgery. For instance, ghrelin, a hunger hormone that's produced 95% in the stomach, increases to increase appetite, to increase weight. The other GLP-1s and the CCKs and all the other intestinal hormones also decrease to try to gain back weight. On the flip side of that, the metabolic adaptation occurs. So when we lose weight, unfortunately, we lose lean body mass and our metabolism decreases. So as I said, that's why exercise and weight-bearing exercises are crucial, not so much for weight loss, but for weight maintenance because of this metabolic adaptation that occurs. So the whole patient approach to patients with obesity, considering bariatric surgery, is needed. Before surgery, perioperatively, but most importantly, after surgery to try to mitigate any weight regain that may occur. So in conclusion, weight regain is not uncommon and should be anticipated over time. We want to educate patients preoperatively that regular follow-up will decrease the risk of weight regain. Accountability with weekly weigh-ins, encourage support groups, adequate protein, regular exercise, and consider early intervention of anti-obesity medications. And most importantly, don't be judgmental. It's not the patient's fault. It is the biology and physiology of obesity and the weight regain that ensues. So we've heard a lot about the emerging medications, and Dr. Ryan is going to go into much more detail, but I just want to lay the landscape of how far we've come with regards to anti-obesity medications. So remember back in what I call the first generation of medications back in the 90s of fen-phen. And then we had the second generations of the phentermine topiramate, the naltrexone, bupropion, and the liraglutide, the once daily GLP-1s. And you can see that we've never been able to crack that nut of 10%. But more recently, with the semaglutide and the tirzepatide, we're consistently getting above 10% and actually 15 to 20% weight loss. And you can see it's rivaling the sleeve gastrectomy, about 25% average weight loss, and the gastric bypass, about 30% weight loss. So it's a great time to be in the field of obesity medicine and cardiometabolic disease with these medications and emerging medications that Dr. Ryan's going to talk about. But before Dr. Ryan comes out, I just want to review the goals for today. We want to learn how anti-obesity medications impact weight and complications related to obesity and cardiovascular disease, discuss practical strategies to tackle the common issue of weight regain after bariatric surgery and understand the cause, and finally explore how use of anti-obesity medications before and after bariatric surgery can support patients through the whole process before surgery and after surgery to make them the most successful in the long-term weight loss journey. Thank you. Okay, without further ado, it is my pleasure to welcome my friend and colleague, Dr. Donna Ryan. Welcome, Donna. Thank you for being here. So excited to see you. Have a seat.
Thank you, Chris. I'm delighted to be here. You know, you've been a longtime proponent of using bariatric surgeons and medical obesity specialists together to really advance patient care. And so I'm delighted to be part of this because you've taught me, and I believe that we really need to have a team approach. We need to use all the tools in our toolbox, bariatric surgery, medications, lifestyle programs, all together. So thank you. Thank you so much for having me. Delighted to be here. Okay, so you showed this slide, and let me add something to it. So what we're looking at here is the average weight loss that occurs in different studies of different obesity medications, the newer obesity medications, bariatric surgery, and then upcoming and emerging medications. So these are average weight losses. These are not head-to-head studies. They're from single studies that we've displayed here. But you also pointed out the variation in weight loss response, and I want to underscore that. So these are averages, but there's a lot of variation around that average. So even though on average, our surgical procedures give 25 and 28.6% at 5 years, that's average. Some patients are not doing that well. Similarly, some patients on the newer anti-obesity medications that are producing almost 15% and 21% weight loss, as shown here, some patients don't achieve that much weight loss, but some patients achieve more. So I think the way to look at this is to consider that these medications and surgery can be used together to magnify the amount of weight loss and to address insufficient weight loss that can occur with bariatric surgery. And bariatric surgery can be used in patients who don't achieve enough weight loss with medications alone. So great way to start. That's right. Great way to start. Okay, and I also want to give a nod to bariatric surgery about these new medications. You know, everybody's so excited about the new GLP-1 receptor agonist. But look, this idea comes from bariatric surgery. You know, this is a pivotal study that was, the first author was Carel LaRue. And what he did is he studied patients postoperatively from bariatric surgery, and he showed that appetite decreases within days of surgery, and that the amount of appetite decrease correlates with levels of PYY and GLP-1, two gut hormones, and that the better weight loss corresponded to the better increases in PYY and GLP-1. So what this really illustrates is that bariatric surgery is not working through mechanical means, it's working through biologic means. And I think this really it really underlay all of the drug development around those GLP-1s, and it's why we have the medications we have today, which are producing so much robust weight loss and so much improvement in the complications of obesity. So we really need to, first of all, acknowledge bariatric surgery's role in developing these medications.
So if you have a patient with inadequate weight loss, do you think measuring GLP-1s or the incretins has any value clinically?
Not really. And, there's a lot of individual variation in response, so we don't really have validated cut points for where incretin levels we would need to react to them. Yeah. So what we're looking for in these in these gut hormones, and sometimes they're called incretins because they have effects on glycemia, in that they promote insulin secretion when there are high levels of blood glucose. But I think they're better termed nutrient-stimulated hormones because they don't all have this incretin effect. So the ones that we're looking at probably the most frequently are GLP-1, GIP, and glucagon. And I'm showing you the different aspects of these naturally occurring hormones. These are all secreted in response to a meal, in response to food reaching different parts of the intestine. And so the GLP-1 is the first one to be exploited pharmacologically. So it has indications in diabetes, and we have multiple GLP-1s that are available for treatment of type 2 diabetes: dulaglutide, exenatide, liraglutide, and now semaglutide and tirzepatide. So the effects here are on glycemia, but also on a reduction in food intake. GIP has been added because GIP has an additive effect on appetite, and it produces more weight loss than GLP-1 alone. People are interested in glucagon too, because glucagon receptors are found in the liver, and we have some evidence that by combining GLP-1 and glucagon, we could get even better effects on mobilizing liver fat and improving liver fibrosis important in MASH. So these are some of the nutrient-stimulated hormones. Other ones would be cagrilintide, which is an amylin analog. So amylin would be another one that would be added into that group. So I think we've exploited these for diabetes, now weight loss, and we're moving into the territory where we're looking for other indications for these drugs. There's an important effect of both GLP-1 and GIP, and that is reduction in gastric emptying. We're going to come back to that comment later. So I think the first thing to do is to set your expectations around what kind of weight loss we're going to see with these newer medications. So first of all, the first one to be approved for chronic weight management was liraglutide. It produced modest weight loss, about 5 to 10% active weight loss over about 6 months, and then sustained weight loss as long as the drug was continued. But the development of semaglutide, a GLP-1 receptor agonist with 94% homology for that GLP-1 receptor, that is a real breakthrough because of the amount of weight loss. And I want you also to notice, Chris, the duration of the active weight loss period. It's longer than we're used to in those older anti-obesity medications. Patients are losing weight for longer than 1 year, and then the weight loss is sustained as long as the medication is sustained. The next breakthrough is that GLP-1 plus GIP receptor agonist, tirzepatide, and that is producing additive weight loss, even more weight loss, because we have two mechanisms of action, both GLP-1 and GIP. So, how much weight do we really need to lose to get health benefits? Well, there's a strong link between weight loss and cardiometabolic health. And the closest link is really in glycemia. So for diabetes prevention, we don't need much more weight loss than about 10% for people who have impaired glucose tolerance to prevent them from progressing. But more weight loss improves dysglycemia. So for people with established type 2 diabetes, with early diabetes, when we're trying to get them into diabetes remission, we need more weight loss, at least 15% weight loss for diabetes remission. And then more weight loss produce even more glycemic benefits. In some cases, that relationship between cardiometabolic benefits and weight loss has a threshold effect. And that's true for obstructive sleep apnea. We don't see any benefit until we exceed 10% weight loss.
And before the newer medications, that was only achieved through bariatric surgery.
That's right.
So it's really exciting, not only for weight loss, but for the improvement in all these comorbid medical problems.
Absolutely. Before these newer medications, it was really hard to get 10% weight loss. We had to work hard on our lifestyle intervention. So one thing about the newer medications is we don't have to work as hard on the lifestyle intervention, but that doesn't mean we shouldn't ignore it. More on that later. But anyway, so there's this threshold effect, but in general, Chris, more weight loss brings more health benefits. So for patients who have more severe obesity and more severe complications, look, we need to be achieving more weight loss. We need to be aiming for 15% weight loss, 20% weight loss, even 25% weight loss. So how do these medications work to improve cardiometabolic risk? Well, some of it is through weight loss itself, and there are some actions directly through the medications. For example, for glycemia, the GLP-1s have independent effects on glycemia. But all of the medications that produce weight loss itself will improve blood pressure, lipids, and glycemia. We have to be careful about some of our older medications, though, because they have sympathomimetic effects. They'll increase blood pressure and pulse. So, for example, naltrexone and bupropion is sympathomimetic, and we do observe higher blood pressure and higher heart rate than we would ordinarily see with the amount of weight loss that we're getting with naltrexone and bupropion.
Do you think that's clinically relevant, though, in everyday patients?
Well, I think what we need to do is on patients on naltrexone and bupropion, we are monitoring blood pressure and pulse. As long as they're down and they're in the range we want them to be, fine. For patients who are susceptible to those sympathomimetic effects, we need to stop and try something else.
Just like phentermine.
Exactly. Yeah. Exactly. Heart rate is a different matter. We do see a small increase in heart rate with the GLP-1 medications. So it's usually about 4 to 5 beats per minute, and it's not sympathomimetic. It's due to the fact that there are GLP-1 receptors on the SA node, and it's thought to be benign, so not an issue there. It's one thing to say, we get a lot of improvement in blood pressure and we get improvements in lipids and the blood sugar goes down. But it's another thing to say we can reduce cardiovascular events and improve hard endpoints. And one of the things that's always been an issue with our weight loss medications is that we have shown improvements in intermediate risk factors, but we never, until SELECT, showed a benefit in terms of events, cardiovascular event reduction. So all of our other anti-obesity medications did not have positive cardiovascular outcome trials. SELECT was the first, and it's important. I do want to give a nod to tirzepatide because it has a cardiovascular outcome trial underway, SURMOUNT-MMO. And of course, we want this to be a class effect. We want SURMOUNT to be positive, but we have to wait and see. And we'll get that data in 2027. So watch this space. But here's the SELECT data. So what's important about this study is it's the first study in patients without diabetes. When patients have diabetes and we give the GLP-1s, we have positive cardiovascular outcome trials. We know that. But in patients without diabetes, with obesity, does treatment with a GLP-1 semaglutide reduce cardiovascular events? That was the purpose of this study. And so it took people who were at very high risk. They had obesity, they didn't have diabetes, they had had a prior MI, a prior stroke, or symptomatic peripheral artery disease. And then they were randomized to either placebo or semaglutide. and they were followed not on a weight loss intervention, but on just good cardiovascular risk reduction recommendations around blood pressure control, lipid control, and such. And they were followed until a pre-specified number of events occurred. And there was a 20% reduction in heart attack, stroke, and cardiovascular death with semaglutide use.
Yeah, we participated in that study. It was a great study. But the 20% reduction, is it from the weight loss or is it independent? Is it semaglutide causing the improvement?
What a great question. What a great question. And now all of the secondary papers are trying to answer that question. So there's some evidence, that the mediation of the benefit would be through the weight loss itself, but it does not explain all of the risk reduction. So we think there's probably an effect of semaglutide itself. And Chris, GLP-1 receptors are throughout the body, and they have effects on, yes, appetite, weight reduction, glycemia. They also have effects in the kidney. They promote natriuresis and diuresis. They have effects, GLP-1 has effects in inflammation, very powerful anti-inflammatory effects with semaglutide. It also has effects on blood pressure, and it has effects on cardiovascular disease itself. It's thought to have cardioprotective effects from data in animals. So the answer to your question is probably both. Yeah, it's both weight-mediated and it's through the effects of semaglutide itself.
Effects in the liver, too, that I'm sure you're going to talk about.
Yeah, that's right. Coming up. Okay, so here's this was a renal endpoint that we looked at in SELECT, and this shows an 18% reduction in our composite kidney endpoint. And this was a 5-component kidney endpoint. But I think what this says is that these are cardiorenal metabolic properties that we're exhibiting here with semaglutide. So we're also seeing other studies that are looking at the renal effects of the GLP-1s, and that's going to be very important. And that's not all, Chris. I want to run through some other things that these GLP-1 receptor agonists, and especially semaglutide, are showing us. And one is heart failure. Heart failure with preserved ejection fraction. We have 2 great studies in this that show improvements in feeling and function in patients with heart failure with preserved ejection fraction. And with tirzepatide, we have a study that shows not only improvements in feeling and function, but also a hard endpoint, improvements in heart failure visits, hospitalization, oral diuretic intensification, and cardiovascular death. So we used to worry about treating patients with heart failure with these medications. This is really spectacular data that we're getting on these GLP-1 receptor agonists and heart failure. Same thing with obstructive sleep apnea and also with MASH. So tirzepatide and a new investigational agent, survodutide, are showing incredible improvements, not just in removing liver fat, but also in improving the fibrosis and the inflammation component of MASH.
And that may be independent of weight loss too, right?
Exactly. And that would be a very, very good thing.
Yeah, we're doing that synergy study. It's hopefully it'll be very telling.
Yeah. So, I think that the points I'm trying to make here are that, everybody's excited about the amount of weight loss that we're getting with these newer medications, and that's good. And we've long known that they are great medications for diabetes, but we also have very powerful evidence of cardiovascular risk reduction. These are not just obesity medications and diabetes medications. These are cardiovascular medications too. And we're seeing emerging evidence that they may have a renal use. Maybe they're chronic kidney disease medications. They're heart failure medications. There's emerging evidence that this anti-inflammatory may be important in the brain. Neuroinflammation, wouldn't that be wonderful? And MASH. So I think we need to really sort of rethink these medications. They're powerful agents, not just for weight loss, but for weight loss and glycemia and cardiovascular disease, and potentially for many other uses.
So how do you think these medications rival bariatric surgery with regards to disease modifying?
You know, we've known for a long time that bariatric surgery is associated with disease-modifying capabilities. We don't really have the ability to do randomized clinical trials with bariatric surgery because it's not ethically responsible. But from our survey studies, we know that bariatric surgery is associated with reduced cardiovascular events. It has powerful effects on MASH and on liver fat, and they have powerful effects on obstructive sleep apnea, mortality. So bariatric surgery has multiple effects on morbidity and mortality. So again, the medications and the bariatric surgery are sort of going along together.
Great. Excellent talk, Donna. Thank you so much.
Thank you so much. It's my great pleasure to be here.
Okay, it is my great pleasure to welcome my other good friend and colleague, Dr. Alan Whitgrove. Welcome, Alan. Thank you for being here.
Oh, thank you very much. Thanks, Chris. Well, hi, Chris. Thanks for having me. You know, this has been one of those issues that I've been very excited about for many years. I wrote an article about 25 years ago, unsophisticated by today's standards, about the use of fen-phen after bariatric surgery. So I've been interested in this area for a long time.
We're glad to have you here.
Thank you very much. I do want to emphasize, and I know Donna talked about bariatric surgery as well, I want to emphasize bariatric surgery is very effective, right? And so we need to look at perhaps the most recent guidelines on bariatric surgery by ASMBS and IFSO. They emphasize the operations are very effective, but you do need a team approach, right? And I think that's where part of the now anti-obesity medications need to follow some of the guidelines for that bariatric surgeons have been following for a long time, because a team approach, I think, is going to be important.
Yeah, I think it's a clean slate. And now is an opportunity to really meld the obesity medicine specialist with the bariatric surgeons.
Yeah.
To make you guys look better.
There you go. And this said long-term follow-up, right? Because we want the best outcomes for the patient. And oftentimes, instead of doing revision surgery now, we can use adjuvant therapy.
Where it should be. You know?
Exactly. So also on those guidelines, and I hearken everybody to look at those guidelines because they do shift the BMI recommendations down 5. So instead of having a BMI of 40 or greater with no comorbidities, now it's 35 and 30 to 35 with certain comorbidities. You know, I like this survey because it puts people in 3 different classifications. And we need to understand as practitioners, in order to get the best response for patients, their best outcomes, we need to understand which of these classifications they stand in, right? Because some people are very benefit-oriented. They want to make sure they get the best outcome for their comorbidities, whereas some people, you know, they're focused on the procedure. They come in and they want an absolute sleeve gastrectomy, even if I think that might not be their best option. And then, of course, I think the people that are the most difficult are the ones that are cost sensitive. Because if they want a malabsorptive operation, for example, but they don't want to pay for supplements, then they're very difficult to take care of.
It's managing expectations. I think that's really important, as you said, because you want to pick the right procedure for the right patient for their long-term success.
Yeah. So we've discussed this a lot over the years at various conferences. What do we do preoperatively? Do we insist on weight loss preoperatively? As you know, I'm not in favor of that. I think in certain individuals, however, if we know that they have a big liver because they have NASH, then shrinking that liver to make it easier on the surgeon ultimately makes it easier on the patient. So I think if we look at this with the adjunct of medications as well, so that we can optimize the patient and not just insist that they lose weight. anti-obesity medications really assist on that.
Yeah, I've written on this preoperative weight loss for a long time, and I've gotten a lot of grief back and forth. So we don't mandate it, but I think that if you can manage their comorbid medical problems more effectively, preoperatively, I think that has some benefit. But, now with the Center of Excellence, I think that the weight loss is secondary to going to a Center of Excellence, a high volume that knows how to care for the bariatric surgery patients. And maybe just a preoperative liquid diet would shrink that liver, and maybe the weight loss isn't as important that I once thought.
Right. Yeah, I agree with that. And the Centers of Excellence have shown that these are not only effective operations, but they're very safe operations, safer than childbirth, for example. So one of the groups of patients that are, I think, probably most important to treat with medications in the liquid diet, perhaps, to decrease their risk are super obese patients, people that have a body mass index, for example, over 50. And this study shows that even up to 60 body mass index, we can get them in a healthier standpoint. We can optimize them so that they have less risk of comorbidities being a problem after and during surgery. And so using these medications at that time to decrease their BMI puts them in a better state.
Do you think, in addition to BMI, do you think how they carry their weight, more android or gynoid, plays a role?
Completely.
In regards to preoperative weight loss?
For sure. It's the metabolic burden, right? It's getting their glucose tolerance better, getting their sleep apnea better, all those metabolic effects. So how do we manage this, right? Around the time of operation, this study's kind of a busy slide, but I think what we need to take out of this is if we're going to use GLP-1 types of medications, we need to understand that they have less gastric emptying. The delayed gastric emptying, I think, is the important part of it. But we shouldn't just think about only the GLP-1s. I mean, if we're giving people medication that has an anti-narcotic, we need to wean those down too, right? Because we want the narcotics to work at the time of the operation. My personal effect on this, my feeling of best practice right now, as the literature shows, is to stop the GLP-1 types of medications about a week ahead of time, put people on a day of liquid diet, and then the normal fasting before that.
We do a 2-week liquid diet, but we do stop the GLP-1 7 or 10 days prior to surgery.
Yeah.
It's really through anesthesia. That is their...
Exactly. But if you look at some of the studies, this is on endoscopic sleeve gastrectomy, and where they didn't, in 57 patients, stop the GLP-1s, and they found that they still were very safe. They didn't have a lot of gastric secretions still in the stomach to deal with. And so I think what we can do is say, okay, best practice is to stop the GLP-1 types of medications a week ahead of time. But if the patient didn't get the memo, or your staff didn't, tell them correctly, we can still say, okay, let's go on a liquid diet, be fasting for a period of time. If you want to, you can get an ultrasound, but I think that's overkill, and you're still safe. I think it's important, if you look at after the operations, that there's going to be a lot of studies coming out in the literature in the next several. You have to look at what type of operation, how long afterwards, and what the criteria were for restarting the medications, right?
Because, the slide that we both like, looking at the trajectories, that first 6 months honeymoon phase, everybody does pretty well, but it's at that 6 month that you can really see they define their success. And so that's why keeping them accountable and intervene early. But yeah, timing after bariatric surgery is a very important, I think, thing to emphasize, because we want to intervene early after weight loss for inadequate weight loss or post-op weight regain.
Exactly. And it may not be anything to do with the patient other than their genetics, right? And so you can't blame the patient.
And the biology, the hormonal and metabolic adaptation that occurs. So, yeah.
Yeah. And I have to say, from a surgeon standpoint, pretty egotistical group, but we feel as though the operations are the thing that does it, right? But there's a lot more than just the operation. So that 6-month period is really important, and then following them closely after that and starting early. I mean, we want the patient to have the right trajectory. We want them to have the best outcome, and so starting early is certainly the best thing. I have another point on that here in just a second, so that's really that's good. The other thing to note is with these medications, there has been shown to be bone loss and muscle loss. So we have to look at that as a team approach. What we want to look at is when these medications are started after surgery and what the indications are. Is it weight regain? Is it early, not enough weight loss? So that's what some of these studies are going to have to show. But it does show, obviously, that semaglutide works really well.
Yeah, I mean, this is a nice non-GLP-1 versus GLP-1. But the fact remains, if you don't have coverage, an anti-obesity medication should be considered, even though it doesn't have to be a GLP-1, although the efficacy is greater in the GLP-1.
Exactly. I like this because you almost never see two slides. There's two lines go right on target, right? But these medications work well if you've had surgery or if you haven't had surgery, and they work almost exactly the same. What we're going to find is there may be a change in this slide on these lines depending on the types of surgery, right? So if they have a sleeve versus a SATI or a gastric bypass, then the weight loss may be different. And I want to emphasize that, we talk a lot about GLP-1s because those are the most effective, but there are medications that are not GLP-1, right? And so for a particular patient, it may be more important or more appropriate for them to have a different type of medication, and those work as well.
Yeah.
When do you start these meds? If you look at those trajectories, and if a patient's on a good trajectory, it's best to wait after that 12-month period of time. People after gastric bypass or after a sleeve gastrectomy sometimes have nausea, as you know. Sometimes they have some vomiting. Sometimes they have some GI upset, sometimes constipation, those things. And you don't want to necessarily aggravate them with medications. So it's best to wait until after that time period.
Early, and just keep them having regular weights and accountability, and wherever that lies, I think is important.
Yeah. So the follow-up's really important on those. And this, just highlights the fact that those adverse events show after that 12-month period of time.
Excellent job, Alan. Thank you so much.
Thank you.
All right, Alan, let's bring back Donna and discuss Madison, shall we?
Perfect.
Welcome back, Donna.
Thanks.
Hi, Donna.
Hi.
All right, so we discuss a case?
Yeah.
So this is Madison. Madison is a 45-year-old woman. She has a BMI of 60, Alan, 60.
Yep.
Weight 350 pounds. She's almost diabetic, A1C of 6.2%, normal blood pressure. She has a past medical history of depression, prediabetes, dyslipidemia, hypertension, joint pain, and easy fatigability. Her weight history, she's had childhood obesity, and she's tried 7 previous weight loss attempts. Only 7. Her current medications are paroxetine, rosuvastatin, losartan, hydrochlorothiazide, and metformin. She says, I've reached a point where I know if I don't do something, I'm going to die. I fought this my whole life. She works as a clerk in a steel mill, and she's concerned about absenteeism. So, Alan, what do you think about a BMI of 60? Is that common? Is that?
My feeling is it should be more common. I think that we've concentrated on patients with lower BMIs, but if you look at people who really need surgical assistance, it's higher BMI, for sure.
You agree, Donna?
I do. We have good data that 10%, almost 10% of the U.S. adults have a BMI of 40 or higher.
Yeah.
So, it'll be lesser as we get these more severe cases of obesity. But, I see bariatric surgeons starting programs, especially for this severe obesity. Yeah. And to me, this is where we really need to concentrate our efforts on multimodal therapy. This is where we need to be using medications as an adjunct to surgery.
Yeah.
We need to be hand in glove and together on this.
Yeah, the average BMI at Geisinger is 51. So they're higher BMI with a lot of disease burden and complications.
Yeah.
And so what do you think is causing her fatigability? I mean, there's many things possible. Any thoughts?
I mean, just think about having that amount of weight on those joints. I mean, it seems like it would be unusual to not have easy fatigability.
Yeah. One thing that I always harp on is obstructive sleep apnea. You know, she's got to rule out obstructive sleep apnea.
Sure.
But yeah.
And the other hot thing, Chris, is HFpEF.
Yep. Good point.
So obesity and more severe obesity is associated with heart failure with preserved ejection fraction. But look, there could be anemia, chronic kidney disease, there are other, and her depression.
And depression. Yeah, very good. Yeah. And so we talk about depression. She's on paroxetine. So we know that that's a medication, a good medication, but it can cause weight gain and retard weight loss. Do you think that's affecting her weight?
I wouldn't say it's a major issue. I mean, could you change that? Of course, you could change it. Yeah. But is it worth changing it if she's been on it and stable on it and that's good on it?
Yep.
Then I wouldn't change that.
But the teaching point is the point is that it can cause weight gain. You want to
for sure.
Good. And so what do you think is the best procedure for her?
Yeah, so a lot of people would say that a SADE or a malabsorptive operation would be her best option. Hearkening back to those 3 classifications of patients that I mentioned before, if she's in the class where they're really worried about what the cost is going to be, a SADE is not going to be a good operation for her, right? It might be the operation the surgeon or the team might recommend. But in today's era of medicine and surgery, I think doing a gastric bypass on this patient, if she doesn't get the same amount of weight loss as you'd like to have, or resolution of comorbidities, add a medication. Don't add in malabsorption, because then it's a whole spectrum of new things that you have to worry about.
Yeah, good point. Good.
You know, Chris, what I'd like to see in this is more research. I mean, I think we need research in stepped care approaches. Should we be using medication before or after surgery? Should we be using our medications and seeing the results, then adding surgery? Should we be doing the surgery, looking at the results, then adding medication? Which procedure should we be using? We need a lot more data.
Yeah, and I think with the GLP-1s, it's a clean slate, because a lot of surgeons, correct me if I'm wrong, BMI of 60, they would do a more malabsorptive procedure right from the get-go.
A lot of people would.
Yeah. Yeah, and I just think, you know, with all the macro micronutrient deficiencies and compliance and things, it's not just one surgery based on BMI.
I
absolutely. You know, this patient made a comment that she said, I feel like this is my last chance. I'm going to die if I don't do something. And we know that this severe obesity is associated with reduced life expectancy. So she's right. We need to do something, because bariatric surgery can be life-saving. And if we choose the right approach and a long-term management strategy with this patient, I feel like we can do some good.
Yep, absolutely. Okay, Alan, would you recommend she lose weight prior to surgery?
Yes. Yeah, absolutely. I think that to maximize her medical conditions, you know, I think absolutely. And from what Donna was talking about, I mean, she may have heart failure, right? Yeah. And so just fact of maybe diuresing her may help. Yeah. You know, it's very interesting just to look at the whole dynamic. Yeah. Yeah, for sure.
But Alan, what if we do use a GLP-1 receptor agonist pre-op in her? How are you going to manage the delayed gastric emptying and the impact of that medication on the surgery that you're going to do?
Right. And we touched base on that a little bit, but I think, you know, right now, the way the literature is, I think we should stop them a week ahead of time, put people on a liquid diet. She might be beneficial to be on a liquid diet anyway, right? And then have a 8 to 12-hour fasting before surgery, and then I think it's fine.
Yeah. So you recommend?
I'm trusting my surgeon.
Good answer. Good answer.
There you go.
All right. So this is a preoperative visit. She has normal iron status, so we looked at that as a cause of early fatigability. We switched from paroxetine to sertraline, and and we recommended some preoperative weight loss to maximize, her perioperative accountability and post-op. So, okay. So touching on the malabsorptive procedures, the long-term support of patients, any patient really with bariatric surgery, vitamin and minerals lifelong is very important. So we see here, vitamin A, thiamine, which is a big thing, the B vitamins, folate, B12, vitamin D, and also calcium, and vitamin D is a big problem with the longer we're out after bariatric surgery. And then monitoring for depression and osteoporosis.
For sure.
So, I think that we underestimate the micro and macronutrient deficiencies in patients the further we're out after bariatric surgery. I know you're very good at monitoring and supplementing, and I think we'll get into that if we have time. I think this type of vitamin we need to be looking at in patients that are on long-term GLP-1s as well. Yep. We've learned a lot from the bariatric surgery. Now patients are losing almost as much weight as a bariatric surgery procedure that, this is going to be important going forward. Again, more studies need to be done.
Yeah. Absolutely. The surgeons are great at producing wraparound care. Mm-hmm. All of their patients see a nutritionist. They all get counseling on the importance of strength training postoperatively and on physical activity postoperatively, on the supplementation postoperatively. We have not done that
well, we've never needed to.
We haven't been able to produce enough weight loss.
Yes, I know.
Yeah, so I think we need to copy the surgeons yet again on this.
Oh, don't get them heads big enough. Okay, so Madison had surgery, and this is her 2-year post-op visit. So you can see her BMI went from 60 to 42. Her blood pressure remained normal. Her A1C went from 6.2 to 5.4. She is taking her multiple vitamins, but she's maintained her weight and then she's gained 10 pounds. So she's had a good response. So how would you manage her, Donna, at this point?
Yeah, so I think 10 pounds of weight regain is not terrible. Mm-hmm. I want to know more about her diet, her physical activity, what's going on in her life, what's her sleep pattern, what's going on there. So before I actually move into treating her with a medicine around appetite, I want to have more information on her.
Good point. Yeah. Good point. Because there's a lot that, after surgery, life goes on and a lot of things can happen. So, even though she's on medication for depression, what we talked about earlier, is she treated? Is she, stable on that? So, but I wouldn't be opposed to an anti-obesity medication. Her BMI is still 40, great from 60.
Right.
But this is where we talked about, the comprehensive adjunctive medication may be effective in her as well.
Yeah, absolutely.
Yeah, you bring up a good point about her sleep patterns because, it rolls into preoperatively assessing her, did she have obstructive sleep apnea?
Yeah.
You can't lose weight if you don't sleep.
Yeah.
Right? You have to have that restoration. So she may still have sleep apnea at a BMI of 42.
She's had a great response, 60 to 42. She's gained 10 pounds. She's not up above 44. Mm-hmm. But still, you want to watch it. You don't want to gain any more weight. You want to intervene early before she gets up to a BMI of 50.
Yeah. And then you're back down to that weight loss phase again.
Yeah. So
completely.
But I think that she had a good response, an expected response from the gastric bypass. BMI 60 to 42.
For sure.
So
would she have had an equal result with the sleep?
I doubt it. Sleep is not as metabolically active, right? And so, I think, unfortunately, it wouldn't be the right operation for her.
Yeah, and it's another reason to consider these medications with sleeve gastrectomy because you don't really have the effect on those nutrient-stimulated hormones that you do with bypass.
Right, exactly.
You could have done a staged approach, do a sleeve, see how much you did, and then do a malabsorptive component.
Yep.
A
lot of people would
look
toward that.
Yep.
Again, I'm not into malabsorptive operations anymore. I've seen some people not do so well over the years.
We have too.
Yeah. So. And now with the medications, we may be able to shift away from that risk.
Yeah.
Because it's a risk for the patient, right?
I think it's so important to really look at patients as, they didn't get this way overnight. You're not going to reverse it overnight. This is a chronic disease. It's a lifelong disease, and we need to take that long-term approach.
Yeah.
So this was a survey that was done 3 years ago. This is a nice little study. So it's looking at surgeons, I believe. How often do you recommend anti-obesity medications to patients in the circumstances? To prevent weight gain after bariatric surgery, to treat weight regain after bariatric surgery, and to promote weight loss before bariatric surgery. What do you think of these results?
Yeah, I think it's probably the way surgeons think. In general, surgeons, bariatric surgeons for sure, are used to stopping more medications than we start.
Yeah.
Right? And so we're more anti-medication. So to add on a medication, a lot of us don't feel comfortable with that. So I believe this. I think, probably a third of bariatric surgeons in general are more toward medications.
I want to see this in 3 years.
Yeah.
I know, right?
Yes.
That's it.
Like what this is reflecting is that 3 years ago, we didn't really have medications that were very effective at all. So it doesn't surprise me that more than half of the bariatric surgeons were not using these.
Well, primary care doctors weren't using them, 3 years ago. So, and I think you make a good point because primary care doctors, surgeons, they're used to treating with diabetes and they're more comfortable. And so even though they're centrally acting, they're not like a phentermine or something that I think they'll be more comfortable with. And they're going to be proven to help their efficacy.
Sure.
I thought that was interesting.
Yeah.
Okay, so, we touched on this before, that, not only are bariatric surgery patients losing a lot of weight, but now we have the GLP-1 patients that are losing a lot of weight. So what about the long-term effects on muscle mass and bone health in both bariatric surgery and GLP-1 use, and most importantly, the combination?
Yeah, I think that we're going to have, we need to have more studies of exercise physiology with some of the long-term effects of the GLP-1 types of medications to look at that. I think it's going to correlate well with how bariatric surgeons have looked at it over the years too. Yeah, I agree.
For young people, I don't think it's a problem because, obesity is weight-bearing exercise. But when we start using these medications for their disease-modifying properties, we're using them in an older, sicker population.
And maybe not a high BMI that has that, increased bone density going,
So in the select population, for example, there was an increase in the number of femur and hip fractures in that population in individuals who are age 75 or older and in women. So I think in an older population, especially in an older female population, we need to be careful about weight loss because when we're losing weight, we're losing not just fat, we're losing lean mass too.
Sure.
And so that's why it's so important to have that wraparound care that the surgeons provide. They provide the recommendations for strength training and for physical activity. And we need to do that too with these medications.
And looking at vitamin D and parathyroid hormone and all those things for those.
Very good. Anything else you want to comment on, Madison?
No, I'm glad she did well.
Yeah.
Me too.
It'd be interesting for me to know how Madison felt about her success.
Good point.
Right?
Is
she satisfied with that, or is she, went different outcome?
She certainly achieved some great health goals. She is normal glycemic. That's wonderful. She's off some of her medications. She certainly has more functionality. So I think the goal in this patient is very much influenced by what the patient's outcomes are. What's the single most important outcome for that patient?
All right, thanks, Donna and Alan. Now let's recap the 5 top takeaways of tonight's program. Number 5, several strategies are available to prevent or reverse weight regain after bariatric surgery. Number 4, one of these strategies is the use of anti-obesity medications. Number 3, perioperative protocols for fasting, holding, or continuing GLP-1s prior to surgery are evolving. Number 2, Some real-world evidence suggests that initiating anti-obesity medications at 1 year post-procedure is associated with higher amounts of weight loss. And the number one takeaway point is anti-obesity medications can be used either before or after bariatric surgery, and the newer GLP-1 receptor agonists produce higher amounts of weight loss. That was great. I want to thank you all for joining us. I hope that you have been able to take away some important information on how to use anti-obesity medications before and after bariatric surgery to optimize outcomes in patients with obesity. Many thanks to my friends Dr. Donna Ryan and Alan Whitgrove for this invigorating discussion, and I hope you gained some important insights from this presentation.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Novo Nordisk Inc. To access all materials for this activity, visit peerview.com/RDF860.